After listening to a lot of STEMI in acute MI, women in cardiology, now I'm talking about LDL-c management, especially the challenges what we have right now. So as all of you know, atherosclerosis, cardiovascular disease, is the leading cause of cardiovascular morbidity and mortality globally. And then, as you know, the last 60 seconds, 34 people have died with atherosclerosis all over the world, either because of myocardial infarction or stroke. So it's a huge burden, and all of us are aware of that. So how important it is this dyslipidemia in an acute MI or acute coronary syndrome. If you take the data from Interheart study, they have shown that lipids are the most critical modifiable cardiovascular risk factors in South Indian patient with acute MI. So it's more than smoking and obesity, hypertension and diabetes and alcohol. So it's about 49% of the population had this LDL cholesterol and it is very high. Again, coming to how this reduction in LDL cholesterol is going to help us. As we know that from all the data, each millimole reduction in LDL cholesterol reduces atherosclerotic events by 10% in the first year, 16% in second year and 20% after third year. And this is quite huge. And all of us should know that the LDL is very, very important in management of coronary disease. But if we see what data would you have, we have data from the real world evidence from India that the LDL cholesterol, the goal is not achieved. 80% of the post ACS patient are not on target LDL therapy despite on statins. That is, the percentage of patient who did not achieve LDL cholesterol, that if you take the goal as less than 55, 79% of the patient did not achieve the goal. And if you take LDL target as 70 milligrams, 55% of the patient did not achieve the goal. So this is all the patients with acute coronary syndrome, about 575 patients. They studied with hypercholesteremia and acute coronary syndrome for 1 year. So there is a huge amount of number of patients where the LDL targets are not met. If you take even 70 or 55. So we'll just go through the three hypothetical patients. What are the problems most of us face in our clinical practice? This is Mr. Abhay, 39-year-old male. He is a young successful software engineer who works around the clock and has a sedentary lifestyle. He has hypertension. He was recently had an STEMI and an angioplasty and stent to RCA was done. He is on atorvastatin 40 milligrams and ezetimibe 10 milligrams and his blood pressure is under control. His LDL cholesterol is still 154 milligrams in spite of ezetimibe and atorvastatin combination. So the treatment challenges in Abhay's are struggling to adhere to his treatment due to his busy schedule and professional demands. So let's see how to tackle this patient. The second hypothetical patient is Mr. Ramesh, who is 60-year-old male and who is a retired banker and enjoys spending time with his grandchildren. He is a known diabetic and hypertensive. HbA1c is reasonably controlled to 7.5. He has undergone 2 angioplasty in last 3 years. Again, he is on rosuvastatin 20 milligrams and evolocumab every 2 weeks. His blood pressure is controlled. His current LDL is 80 milligrams. Still not achieved the goal what we want. So Ramesh finds it difficult to adhere to treatment due to high treatment burden. So this is of existing lipid-lowering therapy. This is a second scenario. The third scenario is Kalpana, 52-year-old female. She is a dancer and leads very active lifestyle. She is hypertensive and obese. And she has explained recently had an STEMI, underwent an angioplasty, multivessel disease, and 2 stents for put for the LAD and 1 for the right coronary artery. So here LDL cholesterol in spite of on rosuvastatin 20 milligrams and ezetimibe 10 milligrams, and LDL cholesterol is 120 milligrams. So Kalpana is more concerned about the risk of another cardiovascular events and what is the safety of treatment, as she is more worried. So we'll take these 3 hypothetical patient and let's see how to manage their LDL levels and what we can suggest. So if you see all these Abhay, Ramesh and Kalpana, they are all very high risk patients. So if you take this classification from the Cardiology Society of India 2023 risk assessment, they have classified into extremely high risk, very high risk and low risk. And all our patients, hypothetical patients, are in the very high risk patient. That is, they have a coronary disease and they had more than 50% lesion in with 2 major vessels. They were diabetic more than 20 years. And they didn't have a CKD. So the target of LDL should be less than 55 milligrams. If you take extremely high risk patient where there is a polyvascular disease in the form of peripheral vascular disease or in the form of cerebral vascular disease and recurrent episode of atherosclerotic vascular disease, the LDL should be less than 40 milligrams. So this, according to the CSI 2023 risk assessment, they come in the very high risk category. But the guidelines are not unanimous in recommending aggressive lower LDL cholesterol. But one thing we know that lower the cholesterol, it is better. For example, CSI guidelines, as I said, extremely high risk, it should be less than 40, very high risk, it should be less than 55. ESC guidelines for acute coronary syndrome management, they say LDL should be less than 55 and LDL reduction more than 50% of the baseline also is okay. But for patient with experience a second cardiovascular event within 2 years and not necessarily the same event in the same subset, the LDL should be less than 40. Again, we have another guidelines from India, that is Lipid Association of Indian Consciousness. They again say that very high risk cardiovascular patient, the LDL should be less than 55. But extremely cardiovascular risk, that is a category A, the LDL should be less than 50, which is recommended, and if it is optional to reduce to less than 30. But if they are in category B, extremely cardiovascular risk, again their LDL should be less than 30. So these guidelines again tell us, even though there are some differences, the lower the LDL cholesterol, it is better. So how to approach our patient based on this ESC 2023 guidelines? So early escalation with a combination therapy that includes PCSK9 inhibitor. For our patient, the first patient, post NSTEMI PCI, and atorvastatin of 40 milligrams ezetimibe, LDL cholesterol is 154 milligrams. So this patient definitely needs to be upgraded to another therapy of a PCSK9. Even Ramesh, post second 2 PCIs, maximum tolerated doses of rosuvastatin 20 milligrams and biweekly evolocumab, still LDL cholesterol is 80 milligrams, which is not satisfactory according to the ESC guidelines. Kalpana, or maximum tolerated dose of rosuvastatin 20 milligrams, ezetimibe of 10 milligrams, LDL cholesterol is still 120 milligrams. So this patient, definitely the goal is not achieved and patient has to be a PCSK9 inhibitor has to be recommended. So summary of these patients, Abhay struggles to adhere to treatment due to busy schedule. He seeks effective and more convenient treatment. Ramesh is not adherent treatment due to high burden of weekly twice injections. He seeks less frequent and effective treatment. Kalpana is concerned about medication safety and risk of cardiovascular events. So all this, they require a effective and sustained lowering of LDL cholesterol. So as of know, I told earlier also, each millimole reduction in LDL cholesterol relative risk of atherosclerotic cardiovascular events are reduced by 10% during the first year, 16% during the second year, and 20% after the third year. And it is reduced by 50 to 55% after a duration of 40 years. So the longer, the earlier, the better. That concept we should understand, all of us should understand. What are the currently available lipid-lowering treatments and upcoming novel therapies? The traditional therapies, all of us know as statins, which are HMG-CoA reductase inhibitors, ezetimibe, which causes cholesterol reabsorption inhibitor, and bile acid sequestrants. Recent therapies are PCSK9, alirocumab, and evolocumab. Newer therapies is inclisiran, that is PCSK single interfering RNA, bempedoic acid. The emerging therapies are evolocumab and gemcitabine, and this is a CRP modulator. So the combination therapy is definitely needed whenever you want to lower the LDL cholesterol. Simply giving a moderate dose statin, you are going to achieve a LDL reduction of 30%. But if you give high intensity statin, it can reduce up to 50%. High intensity statin plus ezetimibe, it can be 65%. Only PCSK9 inhibitor, it can be 60%. But if you give combination of a PCSK9 inhibitor, high intensity statin plus ezetimibe, it can go as 85%. So adjunct therapies are needed to achieve effective and sustained lowering of the LDL cholesterol and prevent progression or development of cardiovascular events. Again, more intensity lipid lowering therapy is associated with lower LDL cholesterol and risk of MACE. If you see baseline LDL cholesterol, which statin is 101 and LDL cholesterol at follow-up is 84 only. Ezetimibe is again 105 and LDL is 66. But if you give a PCSK9 inhibitor, the LDL baseline was 94, it has come to 50. And if you see the odds ratio of the MACE also, the more the LDL cholesterol is reduced with a combination of therapy. Intensive LDL cholesterol, which includes a statin therapy, ezetimibe and PCSK9 inhibitor, was associated significant odd reduction for a MACE. So a combination of therapy definitely not only reduces LDL, even the MACE is reduced in this group of patients. The two data again, the earlier the starting of this LDL lowering drugs, the more the benefit. If you see Miracle where atorvastatin was used here, the early initiation of the lipid lowering agent with atorvastatin 80 milligrams has reduced ischemic events even in the first 8-16 weeks. So the earlier, especially in ACS situation, it has definitely shown that it has reduced event. The A2Z trial phase G, that also it has shown that simvastatin, early initiation of the aggressive simvastatin regimen has resulted in a favorable trend towards reduction of cardiovascular events. What about PCSK9? PCSK9 also have shown that in early post ACS period where the highest vulnerability is there has resulted in a target LDL levels within 4 weeks after the initial event, allowing over the 95% of the patient to achieve the LDL cholesterol. So we are now clear that LDL has to be reduced to the lowest level, and the longer the duration, the earlier the treatment will be beneficial. So then cardiovascular, again if you see the IMPROVE IT trial also, when you do use a combination of ezetimibe and statin within the first 10 days after ACS, the event rate for primary endpoint at 7 years was 32.7%. There is 2% absolute risk difference. So here in IMPROVE trial, when a combination was used when compared to single drug, the benefits was more when compared to single drug. So again, impact of PCSK9 patient with prior PCI at 18 weeks. So this is patients. This is pre-specified subgroup analysis of a patient from the Fourier trial. They have shown that PCSK intervened at the time of randomization have shown that 61% reduction in the LDL cholesterol, 18% major coronary events, and 23% need for additional PCI is reduced, and 24% PCI de novo lesions, and 24% reduction in PCI at previous stent and grafted vessels. So this again shows that this drug when used initially during PCI is also useful. So again coming to our hypothetical patients, Ramesh who is struggling to adhere to treatment due to busy schedule, he seeks more effective and convenient treatment. And Ramesh who is not adhering to treatment because of the monthly 2-dose injection, so he seeks a less frequent and effective treatment option. And Kalpana is concerned about the medication safety and the risk of a recurrent event. Whichever patient will benefit from addition of an inclisiran. So background of this RNA interference came from the generic research on the led to discovery of this RNA interference. A Nobel Prize was awarded to Andrew Fine and Craig Milo, who demonstrated that gene silencing can be done by double-stranded RNA. So this has led to the path of small interfering RNAs, and that's how this molecule was came into the picture. So what are the challenges with PCSK9 monoclonal antibodies? The relatively short half-life of antibodies requires subcutaneous injection every 2 to 4 weeks for many years, perhaps for a lifetime, leading to concern about long-term adherence. So the relatively large quantity of antibodies required, leading to high cost when used to primary prevention in asymptomatic patient with no evidence of atherosclerotic cardiovascular disease. So this is about inclisiran, where statins if you take, you have to take it for 365 days a year, and PCSK9 inhibitor you have to take 26 days in a year, inclisiran you have to take just 2 days in a year. So again the safety and pharmacology and toxicology, it is a not genotoxic or carcinogenic, no effect on fertility or embryonic development, and no dose adjustment needed in a patient with renal impairment or hepatic impairment. So what about any data from inclisiran? There is a robust data. The phase 1 Orion 6, Orion 7 and Orion 12. Phase 2 trials are Orion 1, Orion 2 and Orion 3. Phase 3 is Orion 4. And there is what everybody is waiting for Orion 4 result, that is cardiovascular outcome trial. Orion 5 is homozygous hyperlipidemia. Orion 8, 9, 10 and 11 are also there. Victorian 1, Victorian 2 prevent, both are ended the recruitment, and probably the report should come any sooner. Victorian Block also is another phase 3 study. So you should also understand this concept of cholesterol years. That is a very, very important concept. So the atherosclerotic effect of the LDL cholesterol depend on both the level of the circulating LDL cholesterol and duration of this level. That's both are very important. So the atherosclerotic burden can be expressed in something called as cholesterol years or LDL-c years. Horton et al. Has proposed a very good concept that when cumulative LDL cholesterol burden expressed in milligrams per year, it is also called as gram years, has reaches a threshold, then a clinical evidence of atherosclerotic cardiovascular events occur. So basically LDL-c years is nothing but the duration of LDL exposure the body has. So if you say this graph which is proposed by Horton, I'm not able to get the print. If you say there are three scenarios, if you see the line a person who is having LDL cholesterol of 100 milligrams either naturally or on a statin, who reaches an ASV threshold of 7 LDL-c gram years at the age of 70 years. So this man, if you left alone at 100 milligram and at 70 years he develops atherosclerotic cardiovascular events. But if you see line B, there is a patient with familial hyperlipidemia, that is heterozygous hyperlipidemia. He has LDL cholesterol of 200 and he starts getting exposed at a very young age. So he gets a coronary disease at the age of 35 years. But if you see the line C, if you start interfering this LDL cholesterol at the age of 30 years with inclisiran, the cholesterol will be 60 years and he might live up to 100 years. And this is in a primary prevention. This is suggestion by there is no data as such as. So the Brownwall remarks, he says, it appears likely that approach for primary prevention could delay the significant onset of clinical manifestation of atherosclerotic cardiovascular disease in large proportion of persons similar to those proposed represented by line A, regardless whether or not they required lipid lowering drugs to maintain LDL around 100 milligrams. So this is one of the suggestions maintain how to live without coronary disease up to 100 years of age. So this is the Norton's proposal. So what else? Orion 9 and 11 have shown that patient analysis suggests benefits in cardiovascular with inclisiran. Numerically, definitely the MI and stroke numbers have shown better. So these exploratory outcomes offer early insight that potential cardiovascular benefits from inclisiran and suggest that approach may provide cardiovascular benefits. Orion 8 is nothing but again they have shown long-term efficacy of the twice weekly inclisiran in high-risk cardiovascular patient. Orion 8 is nothing but a combination, all the previous 4 trials of Orion 3, Orion 9, Orion 10 and 11 followed up for additional 3 years, and they also have shown that efficacy of the drug is very good in this group of patient. And long-term safety, that is twice weekly inclisiran in high cardiovascular patient, they have shown that the injection site reaction if you take an Orion is 5.9%, and if you take combination of Orion 9, 10 and 11 pooled analysis is 8.2%. So inclisiran could reduce LDL cholesterol in long term which is being well managed. So this is inclisiran is the first and only LDL lowering drug which is indicated for healthcare professional administration with 6 months dosing guarantee. They just need to take 2 doses, but the first year initial dose, and with a gap of 3 months you have to take second dose. Then after that every 6 months you have to take. The first year you might be taking 3 doses, and after that 2 doses per every year. So what does the addition of inclisiran mean for patients like Abhay, Ramesh and Kalpana who are our hypothetical patient? So just a patient has to need a 2 yearly maintaining dosing schedule, and that effective and sustained LDL cholesterol as a complement to maximally tolerated statin in this patient with atherosclerotic cardiovascular disease. And we can have these patients can have ability to achieve EAC 2023 guidelines of LDL cholesterol and recommended dosing guidelines, and the patient the very safety profile of this drug is well known from all the Orion trials. The key takeaways: ACS patients like Abhay, Ramesh and Kalpana are very high risk patients and they require an early intensive lowering of LDL cholesterol. The latest guideline recommend LDL cholesterol as low as less than 55 milligrams per deciliter. PCSK9 plus high statin treatment in most medication post ACS patient. The rapidly lower LDL cholesterol reduces the recurrence of recurrent events. Inclisiran, the first in class messenger RNA interference RNA for lowering lipid lowering, offers the advantage of 50% effective and sustained LDL-c cholesterol reduction, is a favorable safety profile and a convenience twice yearly dosage. Thank you very much.